over the years, the body gets used to the protein, to the peanut protein, and stops reacting to the peanut. So the idea here is that you would teach the immune system not to attack beta cells. And we know that this works for allergies, so many researchers have tried it for type 1 diabetes. It's obviously a lot harder for type 1 diabetes. For one thing, your body's immune system is attacking 5 different proteins or 5 different parts of a beta cell. So presumably, to train the immune system not to attack, we might need to do it 5 different ways. And so far, people have only been trying one at a time. One of those things that the autoimmune system attacks is insulin itself. And I should say insulin in the context of a beta cell. Type 1 diabetes is not an allergy to insulin. However, it is, or at least part of it, is an immune reaction to the insulin that's in beta cells. So, some people are trying to give insulin to people who are in the honeymoon phase or maybe before the honeymoon phase in the hopes that they will not come down with type 1 diabetes, or that it'll get better over time, or that they'll be able to retrain the immune system not to attack it. That's in phase 2 trials. They did try insulin in a phase 1 trial, and the results, frankly, were not good. However, they reanalyzed the data, and they found that some people did have a good result, not a cure, but a better result, and other people didn't. And they think they know why that happened, so they're doing the phase 2 trial on the people, on the kinds of people who had the best reaction to the phase 1 trial. This thing, IBCVS01, it finished phase 1 trials also. It had also very small results. Again, the researcher is very positive about it, and so he's trying to figure out how to make it better and get it into a phase 2 trial. Pro-insulin peptide refers to a specific part of the insulin cell, and again, you're giving people a little bit of this particular peptide. A peptide is basically a small protein. And so they give people a little bit of that and then a little bit more, and they're hoping to train the immune system. None of these have been particularly successful to date. Any questions about these?
What kind of insulin are they giving them? Human insulin? I mean, all our kids take insulin.
Yes, all of our kids take insulin, and that is one of the sort of surprising things about this research, and it has to do with how the immune system works in a level of detail that I don't understand. However,
there's something you don't understand?
There are lots of things I don't understand. I am a font of trivia, but I don't know all trivia. My understanding is that the insulin they are giving them is human insulin. It's the same kind of insulin that you inject. However, in the cases I know of, they were actually giving it in a pill. And of course, that's another thing I don't understand, because insulin, being a hormone, is digested. Right? A hormone is a protein. Your body digests protein. If you give it to somebody in a pill, it should get digested. This is why we take insulin via injection, not via pills. However, for this particular experiment, they gave it to them in pills in a special form. And some related experiment, they've tried giving them in very specifically designed pills that would dissolve in the intestine in a very specific way, and that was part of why it was effective, or why they hoped it would be effective. I'm sorry, are there any other questions about that? Okay. Another way to attack the immune, or to stop the autoimmune attack, is by rebooting the immune system. And this is exactly what it sounds like. You basically give people a very powerful drug that completely kills their immune system. And this is very dangerous. And these people are in a hospital isolation ward when you do this. You then give them 2 more drugs, which essentially causes their body to regrow a new immune system. And the new immune system doesn't auto-attack. It doesn't attack its own beta cells. So you're essentially rebooted the body's immune system. The result, this has been done by 3 different groups, right? One group in Brazil, one group in Poland, one group in China. They all got very good results. these people, in some cases, they were followed for 5 years and they didn't have to inject insulin for any of those 5 years. Not everyone, by the way, had a result that good, but a lot of people did. And some of the people who didn't have the result of sort of not needing to inject for 5 years, they didn't have to inject for maybe 3 years or 4 years. I mean, overall, it was a very strong, good result. The downside is buried somewhere here, which is that because you are completely destroying the person's immune system, there is a chance of death from this. I talked to one of the researchers who did this, and he said that his estimate, when he told his patients, was that there was a 1% chance of dying from this. From that point of view, it's way too dangerous to be considered a cure by my standards. But the results are the strongest we've seen. Also, by my count, something around 70 people have gotten this treatment. None of them have died. So it's possible that this 1% is a little high. You know, maybe it's only 1/2 of 1%. But from my point of view, even 1 in 200 is too great a number, much too great a number. But it does show the possibility of curing type 1 diabetes by manipulating the immune system. Yes?
So is this like a bone marrow transplant?
It's in some ways like, it's not actually a bone marrow transplant, but it's in some ways similar. One of the drugs that they give people is a drug that is specifically designed to cause the body to generate more cells that are specific to the immune system. So and like, you know, bone marrow transplants have the same, you have to be in a sterile environment. This has that same thing.
So the death, the causes of death would be as a result of not having the immune system, or would it be because of the drugs that they're using to kill the immune system?
Well, remembering that no one actually died,
Oh.
the risk of death, yes, is from the loss of your immune system. Yeah.
So when they were doing this test, were they able to determine if the beta cells regrow, or did
Oh,
they just
yeah.
do it with people in honeymoon?
Oh, no, they only did it with people in the honeymoon. And in fact, they found they got better results when people were earlier in the honeymoon. So the people who got treated within 6 months of diagnosis, within 6 weeks of diagnosis, had the best results. It was interesting. The first group to do it was in Brazil, and they didn't publish that, or they published a little bit of that data, but the guys in China really focused on that, and they found that the people who were treated earlier had much better results. Yeah.
Do we really think we can totally believe the China data? Yeah. But especially China, they've had some research results that have been retracted recently.
Right. So, okay. The first results were published were based on the Brazil research, and they were published in sort of standard American medical journals. And similarly, the Polish results have been published in sort of very normal standard journals. So there's no reason to focus on the fact that one of the sites was in China.
So you say there people often go for years, but it doesn't sound like a permanent result. I mean, do you have to get this done again after 5 years or 10 years? I guess I don't know.
The answer is that I don't know. The published results for the longest group of people were for 5 years. Some of the people had never injected insulin for all of those 5 years. That was the longest term follow-up I've seen. After that, I don't know. Yeah.
I'm very surprised by this. This sounds like a cure. So is anybody in the U.S., any group working on this? Why not, I guess?
It does sound like a cure.
Yes, it does.
The answer is that the Brazil group that sort of pioneered this was working off some theoretical work that had been done in the United States by a guy named Burt. If you hear somebody talk about Dr. Burt's work, that's this work. So the theoretical work was done in the U.S., or part of it at least was done. I don't believe anybody's following it up in the U.S. I believe that if you told people that their children have a 1% chance of dying in this clinical trial, you will have a lot of trouble recruiting anyone for such a trial.
Especially at the honeymoon phase.
Right, yeah, especially in the honeymoon phase. Remember, you're asking people who have been diagnosed within 6 weeks for this kind of thing. So, I mean, I don't know of any work in the US, and I think it's unlikely that there will be work in the US, unless they can find a kindler, gentler version of this. They find less toxic drugs, or they find a way to do something similar without completely shutting down your immune system. Any other questions about this? Okay. Blocking the immune system. This is sort of the simplest approach. You know, the immune system is attacking the wrong cell. If you can block that attack, you can stop the autoimmune attack. The problem with this is that the immune system is very important. You can't live without it. So you want that blocking feature to be very specific. As you know, the more specific, the better. There are a lot of researchers who in the past and right now are trying to block different parts of the immune system. One of the things that I'm not going to tell you is how the immune system works. And the reason I'm not going to do that is because it's really complex. And there are like 20 different cells. And each one of those cells has different types, and they have little names. CD3 is one type, CD4 is another type, CD127 plus is another type. It goes on and on. But because there's so many different cells, you can attack each one of them. And different researchers have tried that. So this drug here, rituximab, attacks what's called the CD20 cell. I'm not sure, I mean, BCG, I believe, goes after the CD8 cell. Every one of these drugs goes after a different part of the immune system. Every one of these researchers is trying to find something that will block the bad autoimmune attack a lot more than it blocks the immune system in general. Some of these are in phase 1, some of them are in phase 2. It's fairly early with all of them, but this is a big part of how researchers in the past at least have tried to cure type 1 diabetes are different types of blocking mechanisms. One thing that's a little complex is when I described it to you earlier, I described phase 1, 2, and 3. It's important to remember that not all drugs go through phase 1 trials. So for example, these 2 drugs here skipped phase 1 entirely, because they've already been used for other treatments, for other diseases, so they already had a safety profile, so the FDA approved that they could be treated for type 1 diabetes starting with phase 1. So what that,
Phase 2.
I'm sorry, starting with phase 2. What that means is that they have a greater chance of failure in terms of effectiveness, because normally if you saw phase 2, you might say, oh, well, how did it work in phase 1? You know, is there good news from phase 1? For these 2 drugs, there is no good news from phase 1 because they were never tested in phase 1. Was there a question back there?
No.
Okay. Okay, the fourth way to go after the immune system is rebalancing the immune system. Now, I described all that, you know, the immune system is real big and complex. Part of that complexity is that the immune system knows that it's going to generate bad cells, cells that attack itself. So to counteract that, it also generates what's called regulatory cells. These are parts of the immune system whose job it is to stop other cells in the immune system that are malfunctioning, that are attacking the wrong cells. So you can view it as sort of a balancing act. You want to have enough regulatory cells to counteract the broken cells that are attacking your own beta cells. So some researchers view type 1 diabetes as being that this balancing act is out of whack. Either the body is generating too many bad cells, or maybe it has too few regulatory cells. So what these 2 groups here are trying to do is put in more regulatory autoimmune cells. Now this could be a lot safer than the other system, right? Blocking cells hurts your immune system, but adding more regulatory cells may just be all good. This is also more complex because the other treatments were all drugs, so you dose them. These two treatments both have the same basic mechanism, which is you take some of these regulatory immune cells out of a person. You then grow a huge number more. You put in chemicals and so forth that cause them to grow a huge volume of these, and then you put them back into the same person. So you don't have any problem with rejection and you don't have any problems with transmitting diseases because you're taking cells out of one person, putting them into the same person. So there's one group up at UCSF who's doing this, and they are using a system very similar to a system being used in Poland to try to do the same thing. And they are sort of focusing on growing up one kind of regulatory immune cell. And then Diovax is a company in San Diego, and they are trying to start a phase 1 trial for growing a different kind of regulatory cell. And the results from UCSF and Poland, actually, they both got very similar results, were actually quite strong for a phase 1 trial. This was all done during the honeymoon phase, and the people basically had to inject less insulin after this trial. And so the hope is that maybe if we get better about growing out these cells, or we do it earlier, or we do it more often, that this could, the sort of promising results nowhere near a cure that were seen in phase 1 could be improved enough so that they would turn into a cure. Or I shouldn't say turn into a cure, turn into a successful way to stop the autoimmune attack. We would still then need to regrow the beta cell. Okay, we're getting near the end. There's only 2 more slides left. One of them is this one, which are autoinflammatories. This is actually based on a different theory about what causes type 1 diabetes. So the normal theory is what I explained up front. Your immune system attacks its own beta cells and kills them. Another theory is that the immune system does something that's broken in your pancreas, and that causes inflammation. And it's the inflammation which then ends up killing the beta cells. So if you could stop the inflammation, you could stop the symptoms of type 1 diabetes. Because sure, the immune system would still be broken, but because you repressed the inflammation, the beta cells continued to live, and the body and the person never actually developed type 1 diabetes. There are actually several drugs that have been tested based on this theory. The one that's gotten the farthest through is this one. I'm not even going to try to pronounce its name. Everyone calls it AAT. So AAT has been through phase 1 trials, and the official results from the phase 1 trials were not very strong. They saw very, very small results. However, some of the researchers involved have also, or not the researchers themselves, but other people have given the drugs to people who have type 1 diabetes in an off-label use. So these people were not part of an organized trial, and they could do that because of certain American laws that allow them to do that. But the results is that in these sort of off-label uses, they have reported a very strong result. And so I'm not actually sure what to make of this. The official results from phase 1 are very, very small. The anecdotal reports from some people who got it off-label are much stronger. The good news is that it doesn't matter which one was right, because these guys have already started a phase 2 trial, and if the phase 2 trial has results similar to the anecdotal reports, that's going to be great news, because that means that these people are very close to having something that would cure people in the honeymoon phase. On the other hand, if the phase 2 results tend to look like their previous phase 1 results, it probably won't move forward any, because the phase 1 results were not particularly interesting. Any questions about inflammatories? Inflammatories, by the way, or I should say anti-inflammatories, is a huge class of drugs. So AAT is the one that's gotten the farthest in terms of testing in type 1 diabetes. But there are dozens, if not hundreds, of these drugs out there. And if it turns out that this is the mechanism behind type 1 diabetes, people will be testing a lot of these anti-inflammatories to see if they've worked. And they have tested some in the past. Aspirin, for example, is an anti-inflammatory that's very common. And people have looked at giving aspirin to people who have type 1 diabetes, and it doesn't seem to to have any effect. But perhaps we need a stronger anti-inflammatory or a different anti-inflammatory. Yes?
Alpha-1 is the one that's actually produced in the body.
Yes, this drug, alpha-1 antitrypsin, is a naturally occurring chemical in the body, and the drug is already approved and on the market for people who don't make it themselves or who don't make enough of it. And people used to think this was a very rare disease, but they're now finding out that it's a little more common than they thought. But in any case, the drug's approved for that treatment. And that's why they were able to give it to other people, because it's out there in the market. People can write prescriptions for it. Yes?
So are these drugs being tested, is there any relation between them and the anti-inflammatory drugs that are currently on the market for, let's say, rheumatoid arthritis, which is also an autoimmune disease?
Right. The answer is AAT is very different than all the ones that are used for treating rheumatoid arthritis and that sort of thing. Some of the drugs used to treat rheumatoid arthritis have been used to try to treat type 1 diabetes also. In general, they haven't been successful, which is why I'm not listing them here. Other questions? Okay. Finally is the miscellaneous category. Some drugs, we don't know why they work, but they seem to work, so they get tested in people. And Gleevec is a great example. Gleevec is a cancer drug. It's supposed to be a very a breakthrough cancer drug. There is no obvious reason why it should cure type 1 diabetes, or at least no reason that I can understand myself. But someone gave it to mice who have type 1 diabetes, and it cured them. So, based on good results in mice, people are testing it on people. And that research is actually being done up in San Francisco also. And that's another one. Gleevec never went through a phase 1 trial for type 1 diabetes. Because it's used in cancer, it skipped straight to a phase 2 trial. This one here, the stem cell educator, is another one that's really sort of in its own category. In this case, the researchers take stem cells and they, in a sense, put the stem cells next to the person's blood. And there's a membrane between them, so they don't actually mix. But the membrane allows certain proteins to go back and forth between them. And blood that has been exposed to stem cells in this way is then put back into the person, the same person who donated the blood. So again, you don't have to worry about, getting something from somebody else. However, the researchers believe that one of the proteins or some other chemical given off by stem cells affects something in the person's blood that will then cause type 1 diabetes to be not so bad, or possibly to cure it in the future. If I'm being a little vague here, I'm sorry. This is one of the things that I don't understand why it works. However, the results were very strong. When they gave this treatment to people who had had type 1 diabetes for 5 years, they needed to inject insulin, some of them 20% less insulin, some 30%, some 50%. So there was a very strong result in terms of needing less insulin. So and this was in a phase 1 trial. There were about 50 people involved. It was a large phase 1 trial. So again, the hope is maybe if we treat people more often, or maybe we treat people earlier, or maybe we learn how to treat them better, that something in the stem cells can be used to educate the body's immune system such that we can cure type 1 diabetes. The umbilical cord is sort of a similar idea. These studies were for people who did cord blood banking when their child was born. And they then put the cord blood back into the child after they were diagnosed with type 1 diabetes. This was being done in Florida. The results from phase 1 were pretty small, but they've started a phase 2 trial, and we'll see the results from that. And then finally, leptin. Leptin is another naturally occurring chemical, and again, I'm a little embarrassed, but I do not understand why the researchers think that leptin will cure type 1 diabetes, but they do, and they have started a phase 1 trial to see if it works, and hopefully we'll hear about it in a couple of years. Leptin is, like I said, it's a naturally occurring chemical. It's used for a lot of different reasons, and so it's relatively safe and easy to work with, so the researchers don't lose anything by testing it. Any other questions? Okay. These are my favorite references. I'll leave them up so you can write them down if you want to. This is the end of the talk. The first one is my blog. The second one is a paper that I worked on with the Juvenile Diabetes Cure Alliance, which is also an overview of different possible ways of curing type 1 diabetes. It's only 5 pages long, so it's a lot quicker to read that paper than to listen to this whole talk. But anyway, it was sort of a previous attempt to look at the whole breadth of the field. This page here, this Scoop It page, is curated by Ellen Ullman, and it is the best source of public reporting, of sort of mass market, mass media reporting on type 1 diabetes. I'm very down on mass market reporting. I find that the stuff I read on websites is often very superficial. However, Ellen has done a great job of getting all the important stuff, all the news, all the big news on one web page. So it's easier to look at that one web page and see all the news from all the different web pages than any other source. This next one is Diatribe, the homepage for Diatribe. Diatribe is a great organization. They understand type 1 diabetes very well. They are focused on covering it, and they have a staff that is paid to cover it. And they provide a lot of very detailed reports and analysis, and it is the exact opposite of superficial. But it's also very easy to understand, and they're writing it from the point of view of people who have type 1 diabetes, so they're very practical about how they cover a lot of this medical news. And then finally, I can't say enough good things about Brave Buddies, which is a support group for parents whose children have type 1 diabetes. And it's a Yahoo group, and you can go there and join, and it will be a font of great information for you for years or decades in the future. Any other questions? Yeah.
Can you just talk a little bit about the research funding and the role of, say, government funding, nonprofits like the JDRF, and then all of these companies, and how well is all of that working?
So, okay, so the question is asking me about how funding and how well is it working. So let me answer the second question first. We don't have a cure, so therefore we're not successful yet. So beyond that, I don't really have an opinion for how well it's working because I have nothing to compare it to. It's not like some other country is doing a better job funding type 1 research. I don't know. I can't judge how good it is. But let me talk a little bit about how big it is and who's putting money into the pot. So JDRF is by far the largest private funder of type 1 diabetes research, nonprofit funder of type 1 diabetes research in the US, and it's over $100 million every year. The biggest funder is probably the United States government. There's no way for me to know how much money they put in, but there is one program called the Special Allocation for Type 1 Diabetes, which puts in $150 million every year. What that means is that if you guys get email from anyone saying the special allocation is going to be voted on, please write your congressman, please do write your congressman. That's a lot of money that's going into research. I can't even guess the different companies how much money they are putting stuff into. It's clear that Medtronic and Animas and Dexcom and I assume Tandem are putting in fairly big bucks because Medtronic already has a little bit of an artificial pancreas in the market, and therefore those other companies need to keep up or they're going to be left behind, and they know that, and that's their business. Did you have something more specific about funding that you wanted to know?
Well, no, I mean, it's just, you hear classically about, okay, the government seeds the basic research and then sort of companies pick it up, and it just seems like there's such a stew right now that there needs to be a combination of a lot of still very, very basic research going on at the same time as all these commercial paths.
Yeah, so the question was about who funds the different phases and the early exploratory work versus the later stuff when you're actually trying to get a product into market. So classically, yes, there was the government and JDRF at the beginning of the process, and there were commercial companies at the end of the process. JDRF was one of the first nonprofits to really look at the gap between those two and try to fund into that gap. Because before, when I say before, I mean like 30 years ago, there really was a gap where stuff would work at a research lab somewhere, but then sort of no company would know how to deal with it or would consider it likely enough. And so JDRF has worked with companies to try to move things along and also try to put money into that gap more directly. How successful it is sort of a matter of opinion, but they've definitely tried to fill that gap. And as you said, with the stew, in more recent times, we now have venture capital and angel funding, which we didn't used to have, and that's also aimed kind of at that gap. Because I focus on human trials, I'm looking at the end of the process. And so one of the things I can tell you is that none of these things look like they're going to be a cure in the short term, unless you think an artificial pancreas is a cure. Nothing else is particularly close to being ready. And so what that means is that it is important that we fund things earlier in the pipeline, because there is nothing late in the pipeline that's obviously going to be the cure and obviously going to make it to market. So it is important that we fund sort of the middle and the beginning of the pipeline also. Are there other questions? First of all, did I answer that? Okay. Are there other questions anybody has? All righty. Thank you very much.
Joshua, one last thing. And I just want to thank you for the work that you do, and your presentation tonight was very good.
Yeah.
Well, my takeaway, and I'm sure a lot of the people here that have been dealing with diabetes for extended periods of time, years, the more we know about it, the more we realize that this is a real nut to crack. It is super difficult to figure out what's going on. Why is that immune system, why did it clobber my kid's pancreas or my kid's beta cell producer? I mean, and it sounds like, a lot of guys are saying, well, it could be because of this, it could be because of that, could be because, and I'm going to develop a drug that will prevent that from happening, or a drug that, we're all, but we really don't know what. And my takeaway tonight in your presentation is that there's a lot of things going on, but they're really no farther ahead than they were 10 or 15 years ago when I first got introduced to this whole problem and been working with it. So it's frustrating.
Yeah, and I understand that frustration, and in some sense I'm frustrated too, because I've been looking at this for 7 years, and you're right. I mean, there's no obvious cure that's becoming apparent. So right now, there is nothing that cures type 1 diabetes that's being tested in phase 1 trials. There's nobody said, oh, I was in a phase 1 trial and they cured me. And that sort of thing is a prerequisite for the cure being generally available years down the line. So what that's telling me is that we're not going to have a cure, for the next couple of years, certainly. Maybe even out till 10 years. there's nothing obvious to me now that's being tested such that we're going to have a cure in 10 years. And I feel that frustration. I do believe that we're making forward progress, but I agree with you that it's very hard to quantify that. And it's very hard to say when it comes to cure research. You know, when it comes to devices, here's your proof that we make progress, right? That's an insulin pump. It's an insulin pump from a long time ago. Now we made big progress on insulin pumps.
We have insulin.
Yeah,
Yeah.
you're right. 100 years ago, no insulin. These are big forward progress in the treatment of type 1 diabetes. But in terms of curing it, I got to say that I agree with you that the forward progress that's being made is at sort of a basic research level and hasn't crystallized into something that's clearly going to be a cure. You know, even, you know, that I could say, oh, in 5 years, you know, that's going to be a cure after they do 5 more years of research. There's nothing like that out there that I see right now. And yeah, it's frustrating.
I'd like to comment on that. And I think that that's one of the things that we need to be looking at, is that there's current stuff that's going on. We used the Night Scout.
Right.
Okay? That's a help. Okay. Ed Damiano, you talked about that. That's not a cure. What that is a bridge. And to me, that's something that I can do for my child now. And that's why I'm supporting that a lot. Because the cure is 20 years away. You know, as you say, 10 minimum, but we don't have anything on the horizon, so let's give it another, 10 after that. So my son, at that point, will be 32 years old. The cure is not really relevant to my son. I mean, I want to participate and help work towards a cure for his kids. If you want to go that